Good afternoon, good morning, wherever you are in the world. My name is Nick Glickman, and today I'm going to share the boutique labs journey to all on X digital chairside services. So let's jump right into things here. I'm going to share the screen, open up the presentation, and hopefully, let me just make sure you guys can see all of that. Yes. So I've been with Zirkonzahn for nearly 5 years, and it's always very, very exciting to see the boutique labs journey to or from just starting off with the CAD/CAM system and moving towards full mouth rehabilitations. And usually when we start to meet new laboratories, new in-office laboratories. People are in awe of workflows that will tend to look like this here, where we have a complete project established on a virtual articulator. We have the situation models mounted in relation to a STL rendering of the skeleton data. We have the edentulous models. So this we can imagine is a patient that is edentulous with the complete denture. And all of this was mounted because we had 3D face scans that we used, and through a specific set of references, translated the maxilla into the virtual articulator. And certainly we can also introduce tried and true reference planes and reference objects to ultimately help guide our setup in one of the latest innovations on the dental market, the modifier software, which is giving us the opportunity to load a mounted tooth library of various ortho theories, various tooth morphologies, and auto-populate this over an individual occlusal plane, and with a simple click, create a beautifully festooned virtual gingiva. And we can take this structure and adapt it to any type of prosthetic appliance, whether it's a crown and bridge, an implant retained appliance, or even a simple partial removable denture. And this, for a lot of people, is really a novelty to see how far the digital world has brought dental technology. But I must come out very clear and say that some assembly is required. And this idea of building a complete CAD/CAM laboratory around full arch, or an in-office laboratory around full arch, requires a lot of legwork on your part to get to that point, to get to that set of skills. For me, I can relate this to, for an example, music. I love to play and record music, and oftentimes I find myself on YouTube, on the internet, looking at master guitarists and watching them play, and they even have courses on how to get to that point. But then when I put the guitar in my hand, I realize, oh wow, something's not coming right, and I need to exercise and get to a point where I can execute the music just like the master that I was learning from. And I think the same concept applies with CAD/CAM dentistry, is that it's not always just this beautiful set of slides on a screen, but it requires a lot of legwork to get to that point where we can implement these types of treatments for our patients. So this presentation is really designed for new users to CAD/CAM, whether you are finally integrating software or milling machines in your laboratory, or you're a clinician bringing this technology in-house. This lecture is designed for you, and it's to really set out a learning track for us to guide you down so that you can get to that point where we can implement full arch digital chairside services. And before we can start to use the system and the software to design these magnificent restorations, first we need to dial it all the way back to square one. And we need to become very familiar with the principal workflow that underpins a CAD/CAM dental project. And so your first training with Zirkonzahn is going to revolve around how we interact haptically with the CAD/CAM system on a very basic level. And so I'm going to guide you through a couple of the first cases that we will perform together, which gives us the building blocks to go after immediate provisionals in an implant-based rehabilitation. So starting at the beginning, when we think about CAD/CAM, we should really draw an analogy to the conventional laboratory method. And what you see on your screen is basically the Zirkonzahn software desktop. And this is laying out our workflow through a series of software applications you see running across the bottom panel here. So we have, again, this analogy to the analog world where what happens when we receive a case? Well, we typically receive a prescription on some sort of RX form, and we will place this in a lab pan with the impressions. And that is actually what takes place in the first software you see on the left-hand side, the archive software. This is essentially a digital database of all active or past prescriptions. And once we have the prescription inside of a lab pan, we take this, in the conventional world, to the plaster room where we will pour our models and establish these models on an articulator. And in the digital world, we're doing the exact same thing, except this happens in the Zirkonzahn scan software. And once we have the project registered on an articulator, whether it's in the analog world or the digital world, we move this to the lab bench, our waxing stations. And in the Zirkonzahn CAD/CAM suite, this is known as the Zirkonzahn Modellier and the Zirkonzahn Modifier software. And once we have our setup established and tested out on an articulator, whether it's an analog or a virtual articulator, we have to take this wax up through the final fabrication of the dental appliance, whether that's through a casting or an investment technique, or if we're in a digital world, we take that through the nesting and the milling software. So you see, all of a sudden, that magnificent case I showed you at the very beginning, we start to unravel all of the steps that were required to achieve the end result. And if we put this technology in a new user's hands, we should not expect them to get to that point right away. And so we have a very easy method of introducing these concepts. And we do this by means of a 3-unit bridge case, cement retained from the first premolar to the first molar. And we will start by opening up our archive software, and we will create the header of the prescription, and then we will indicate the treatment. And so today we're going to treat the first central incisor with a reduced zirconia crown, and then we will treat the first molar to the first premolar with a 3-unit monolithic zirconia bridge. And once we have this prescription filled out on our digital RX form, we will save this. And now you see under that little project window in the center box here, we have the prescription in what is our digital lab pan. So now it's time to move this to the plaster room, our virtual plaster room, the Zirkonzahn scan software. And here we have a virtual articulator and the opportunity to scan in dental models or import digital models. And so in this demonstration, we'll actually use the desktop scanner, and we take a 3D image within 5 microns of accuracy of the working model. We can trim the model much like we would in our gypsum room, and then we go and it just falls arbitrarily into the virtual articulator. What else is missing? We need removable tooth dies. We like to work with Geller models here. So we'll scan the individual die. We'll assign them as tooth 1-1, tooth 1-4, tooth 1-6, and we will go to match these elements to the working model. And now I have those individual die in relation or superimposed with my healthy or my master model. Now we go to scan the lower, we bring this in, but notice that just like in the conventional method, these models don't just come automatically with a relation to one another. You can see that we do not have a bite established. And so the software requires one final step to do what we call an adjusting scan or a fine adjust scan. And we can do this either by scanning the cast mounted on an articulator, or simply by placing the bite registration between the two models and scanning it, which is what we did here. And we match these elements together, and we have now the upper and lower model in relation to one another. But notice here that they're not yet in relation to the virtual articulator properly. And we'll get into that as we move towards the bigger cases. So before we save, just a recap, we have the individual Geller die with the working model and the antagonist. We go to save this, and we come back to our virtual lab pan, and suddenly all of the models are stored in this virtual lab pan. And we can now bring this to our virtual waxing station, the Zirkonzahn Modellier software, and we are prompted with a step-by-step workflow that takes us to the end of the project. And we start on this simple 3-unit bridge case because this is probably one of the workflows that requires the fewest amounts of steps. But the principles behind these steps you're gonna find them to be universal across all types of digital workflows within this CAD/CAM suite. So we will go to mark the margins, then we will set the crown bottom parameter. So what type of cement gap are we looking for? What type of insertion direction are we looking for? How do we want the margins to seat? What type of protection do we want around the margins in a milling process? And then we go to actually place our beautiful virtual teeth. I think that this is really a great novelty because if you're working in the analog world, you understand how much time and dedication it takes to build morphologies like the ones you see in the upper right-hand corner. And suddenly with the CAD/CAM system, you have access to a wide array of natural tooth morphologies, and your work is suddenly looking very, very magnificent for your clinicians. So we go and we select the tooth library of our choice. The teeth come into an arbitrary position, and we will go to reposition everything for a functional and aesthetic tooth setup here. Now, in the free-forming phase, we can start to assess the contact we have with the antagonist, and we can build this out so we have the appropriate stop centrics, and we can adapt these elements, of course, to the adjacent teeth, and we can adapt the pontic to the gingiva as well. We can then move into the next step where we will apply an automatic cutback to the central incisor. This is giving us a schema for where we might layer our ceramic material. It's emphasizing the mamelons, and it's protecting the incisal edge in zirconia so we can eliminate any sort of chipping that might happen through the abrasions that will naturally occur in the excursive movements. And finally, we go to create the connectors. We made the tooth setup in such a way where we can have these invisible or connectorless connectors. The teeth themselves will support each other. And we bring this to the end into now the fabrication process. So what you just saw was the CAD portion of our workflow. And now we will move that into the CAM phase, the computer aided manufacturing. And notice right on the top of the screen, the software is leading you into the next step. And this is very, very important that when we start with CAD CAM, we just follow the workflow from start to finish. And once we're comfortable, then we know how to move in between the softwares at will. So we just simply place this into our nesting software, and we have now a virtual representation of a zirconia blank with all of the details for that blank shown in the list on the right-hand side. We at our laboratory have registered our 1,602nd blank in the software. So we have a complete log and history of everything we've milled, and we can go to then load the restoration into the puck, position this appropriately so that we have the right types of supports around the structure. And we go to create what is called a CNC file, or a computer network control file. That means that we are going to calculate a pathway for the milling machine to move along so that we can mill out our results. So here we can actually see the visualization of the pathway. I know that this is just looks like a bunch of squiggly lines, but we can toggle between the different burrs that will work, and we can see before we actually produce what the quality of the milling will look like. And certainly you can start to understand, if any areas might not be milled, then we would go back and reposition it, or how well we are going to actually achieve this defined occlusal morphology, for an example. Really, really an amazing, amazing software that we have here. And once we have this, we bring this into the final software, the milling software, the Phrasen software. And this is where we load the puck virtually into our virtual milling machine, and we load the burrs virtually into the virtual tool magazine. And we make sure that these elements in the analog world or at our physical milling machine are corresponding. So we make sure we load the correct puck in, we make sure we load the burrs in the right order, we make sure the machine was calibrated, and then we click mill, and we can start to actually proceed with the post-processing of the restoration. So in your first training, we will also cover some principles of Zirconia Aesthetics, okay? And we're not going to start off with some big full mouth reconstruction. No, we're going to start very, very small and focus on the concepts that will drive us when we go to create full mouth rehabilitations. And so the first step in the zirconia post-processing, once we've removed the structure from our blank, is the color infiltration technique. So this means that we need to start to understand the different color liquids that we have in our bag of tricks and in our toolbox, because each color liquid relates to a specific zirconia. And so suddenly you can start to see, right, that there's a lot that goes into just a single crown. If I mill it in the Pretal material, I need to use the Pretal Aquarelle color liquids. Whereas if I'm going to mill this in, let's say, the Pretal 4 anterior, there's a different set of color liquids that correspond, because the Pretal 4 anterior is more translucent and requires a different concentration of metal oxides, for an example. So we need to make sure we get these things clear before we go and we tackle a big case. And we will show you step by step how we infiltrate the structure through almost like a paint by number sequence. But we do need to make sure you go home and exercise this, because yes, I can show you once and you understand the concept, but then it's time to actually take the concept and apply it manually. And then once we bring this through a sintering cycle, which is also dependent on the zirconia material that you choose, we will go through a 3D stain and glaze technique in your first course. And so we use the 3D stains by Enrico Steger. And again, we have a very nice paint by number sequence, but it's following a specific concept of playing with opacities of materials and playing with chromas of materials in certain aspects of this tooth. And so we go to apply this through the various bakes, and you have a beautiful restoration at the end. So you're going to go home and practice these things, Okay. And if you're in a production environment, especially an in-office laboratory, we'll also equip you with some nice copy milling techniques so you can continue with your production while you're still acquainting yourself with the actual digital workflow or digital tooth setup process. And then we go into the intermediate training. And in the intermediate training, this is where we start to introduce the implant-based concepts within the scope of our digital workflow. And if you remember in the first case we did for that's the CAD/CAM A course, I would say that there's probably 5 to 6 steps within the design process. That's just the design process alone. And in this case, I'm going to show you, I was counting yesterday, and at each step, at the end, I saved each step as what's called a scene, and I noticed that there was probably 22 to 23 steps in this case. And so suddenly the project becomes more labor intensive, more intense. And we will notice that some of the principles from the first course will actually apply here. So again, we open up the Zirkonzahn desktop, our CAD/CAM launcher, and we enter the sequence. So we start with the archive, we create the virtual lab pan. This time, we're going on the upper jaw to restore 2 single unit implant retained crowns. One is going to be on a tie base, the other is going to be on a custom abutment. And on the lower jaw, we will create what we call a pretile bridge element from 44 to 47. And the pretile bridge element is essentially a sequence of pontics that is connected by means of a prosthetic gingiva. So we go to set all of these options in the archive, and then we enter the scan software and we load the upper jaw master model with scan markers. This is an appliance that's used to index and locate the implant virtually. And certainly we also need a representation of the soft tissue. On the lower jaw, it's the same, the master model, the scan marker, and the tissue itself. Now, we notice, just like in the first case, that these models, when we imported them either through the desktop scanner or through an intraoral scan, they come into our virtual articulator in an arbitrary position. It's basically just, they're just throwing them into the coordinate system. And now I would like to kind of talk about the importance of virtual articulators, as we can use these appliances through the virtual setup to understand the excursive movements that will be at play in the mouth. And we know that the articulator is a device that is meant to represent the pure mechanical movements of the patients once we have deprogrammed or eliminated all of the proprioceptors. And unfortunately, in this case, we don't really have any individual patient recordings, but we can use a set of standardized references in the cast mounting window of our virtual plaster room, and we can align the maxilla to the median plane, which is running center of our articulator. We align the skeletal midline of this maxilla to that median plane, and then we load this beautiful mounting table called plane positioner, which gives us an indication of the center of occlusion, which is that x-axis running along the plane, and we go to position the center of occlusion so it intersects with that x-axis on the plane positioner. And now we have a standardized mount. And if you guys are really interested in virtual articulators, I highly recommend you go to the archive of live conferences that we have, and you check out this series called the virtual PS1 articulator, where we take you from a standardized mount to a patient-specific, completely adjusted mount. Very, very neat. And actually, further on in this presentation, we will start to touch on some of the concepts behind the patient-specific mount, which we accomplished through the Face Hunter and Plane system. So now here, we save this and we go into, again, our virtual waxing station. And the software presents us with a step-by-step. We're going to identify the position of the implants through the scan markers. We'll load the different types of implant prosthetic components, whether it's going to be a appliance called a raw abutment, or it's going to be a tie base, or it's going to be a conical tie base that couples with a multi-unit. And we then go to draw our emergence profile around the gingival aspect, so we understand how the tooth elements will emerge from the gingiva. From here, we set the virtual, well, first, sorry, we can also introduce a pre-op scan as a reference, and this is a very important concept to keep in consideration when we enter the final cases at the end of the presentation. Introducing reference objects, this is essentially just a guide for the setup, and will use this to understand the approximate size and placement of the tooth as it currently exists in the mouth, and we make adjustments from there, upper and lower. And then we go in to create the abutment bottom, upper and lower. We then will modify the tooth so we have the appropriate stop centrics. And on the lower jaw, we create the insertion direction, draw the virtual gingiva, create the virtual wax up, and we stamp out the screw channels. So the lower is done. And on the upper, we will then integrate the custom abutment design. And just like in the first course, we will have to set the insertion direction here, as well as the crown bottom parameters, and we save out the final reconstruction with the screw channels, bring this into the nesting software, position it, and go to milling. And as you can see, these are the first principles behind going after full prosthetics in the Zirkonzahn CAD/CAM suite. So if we're comfortable getting through a simple 4-unit implant retained bridge, then certainly we can apply the same concepts to a full mouth reconstruction. But it's important first that we get comfortable with the tools. We apply our formal knowledge. It would be the same in a conventional workflow, but now we're just doing it digitally. We apply this to the tools, we sharpen our skill sets, and then we can feel confident in going after the large cases. So also in the second course, we will expand on the post-processing, the aesthetic aspect of the zirconia structure. And this time around, you'll be comfortable going through the color infiltration on your own, and we will guide you through a simple microfacial layering and layering of the gingival aspect with tissue ceramics. And again, these are the first principles to going after the cases of your dreams, the full arch rehabilitations, where you will need to do color infiltration and you will go to layer the ceramics on this structure. But you see, if we start with something easy, then we can stay cool, calm, and collected and work our way towards a beautiful rehabilitation like the one you see here from our master dental technicians out in Zirkonzahn worldwide, headquartered in South Tyrol, Italy. And now I think we come to the exciting part of this presentation, is how do we take these first principles and apply them to a full mouth rehabilitation. And in your CAD/CAM journey, what we like to do nowadays is actually come to your facility with an amazing innovation that we brought to the market about 5 years ago called Phase Hunter and Plane System. And we will use this with one of your patients or one of your clinicians to essentially register a 3D virtual patient on the PS1 virtual articulator. And this will be the premise of our prototype. This is going to be the starting point of the technical project to engineer a functional and aesthetic prototype for full arch immediate provisionalization. And we need to lay this project out in a couple of steps. So the first step is going to be about actually establishing the technical project so you have the 3D patient registered on your virtual articulator. And this part will entail really a collection and assembly of raw data points. First, we will capture digital impressions, which we can turn around and mill or print through a CAD/CAM process. If this is not an option, certainly alginate impressions will be more than sufficient. We will need to capture CT scans of the patient, which we can export and render as an STL file. Very, very important step. And I believe we're one of the only ones on the market that have this technology integrated completely. We need some extraoral photos of the patient's situation so we can start to understand some of the aesthetic motifs at play. What I see here is two laterals that are rather monolithic, preventing light to come into the structure. The partial removable denture appears to be canted, which gives the impression that the lip line is receding on the patient's left-hand side. And we can also confirm some of the functional assumptions we have with this bilateral balanced occlusal scheme, and we want to move that towards a more canine guided occlusal scheme by actually capturing patient-specific recordings of the maxillary position, which we glean through a device called Plane System. And this will be coupled with 3D facial scans that we capture with the Face Hunter. And all of this information comes together to create the technical project that we will set up in the Zirkonzahn scan software. And suddenly you're thinking, wow, that is a lot more information than what we used in the first two courses. And that's actually why we start with those first two courses, is because we need to keep things very simple. And you will always need working models and opposing models and tooth dyes or scan markers. But now in this project, we're integrating additional components like 2D photography, STL renderings of a DICOM, Plane System, recordings, as well as 3D facial scans. So just the scan software project becomes more intense in and of itself. And how we bring all of that together is really predicated on this amazing device that we have crafted with master dental technician Udo Plaster. It's called the Plane Finder, and it has the very simple scope of registering the patient in a natural head position so we can capture the patient's absolute midline as well as their allotragus plane left and right. That's just an epidermal version of the camper plane, which runs parallel to patient occlusion. And all of these recordings are related or relative to a 0-degree horizontal plane. And practically speaking, it just means that the patient needs to walk into the plane finder, look at themselves straight on in the mirror, position and stabilize their posture by placing one hand on either side of the plane finder. And this basically forces them at ease into a natural head position, which is not a reference that Zirkonzahn is just pulling out of thin air here. This comes from the orthodontic world, from Dr. Maurice in the 1950s from Harvard University, introduced the natural head position to dentistry. And from what I understand, he copied this from a Frankfurt meeting where they were studying skeletal anatomy in the late 1800s. And this is essentially a standardized and reproducible position of the head that gives us access to the proper angulation of the allotragus left and right, as well as the absolute midline. We go with the 3D facial scanner, the Face Hunter, and we capture this natural head position. And now the natural head position is affixed within my virtual plaster room, my scan software. And with the Face Hunter, we assemble a few additional scans: the portrait, the left, the right, the smiling, a series of aesthetic images such as mouth wide open, the resting lip position, the letter A, S, F, whatever you need to assess aesthetics. And we go to merge these individual facial scans together. So again, a theme from the first two courses where we have to take two items and match them together. So these concepts build on each other, but really the intent behind everything, we also need to strive to understand that we are merging this data together so that we can transfer the digital maxilla into a virtual articulator by means of references located on the maxilla itself, as well as the epidermis of the 3D facial scans. And so our software gives us a series of prompts to follow where we will mark the skeletal midline, the masticatory center, and the allotragus left and right. And if we imagine we're this patient facing towards the floor or towards the ceiling, this angle that we draw would increase or decrease in intensity. So the natural head position is absolutely fundamental to understanding the true z-axis pitch of this maxilla, which we have now transferred into the virtual articulator. The lower jaw we bring in, as I showed you in the first two courses, by means of a fine adjust scan, a bite scan, and we will position the lower jaw in relation to the upper jaw through whatever clinical recordings, whether you want to start with a CO or a CR mount, that is your business. And what's missing here is really the alignment of those 3D facial scans to the mounted models, which we achieve by means of this face transfer fork. It's a simple mechanism that the patient bites into, and we scan them with the fork, and we go to physically scan the fork to create a relationship of the maxilla to the impression left on the fork, which is related to the 3D facial scan, and suddenly the face comes into alignment with the mounted models. And this, I think, is a novelty for many technicians. This is a dream to work with. Finally, I can assess the function appropriately while seeing the aesthetic results of my setup in real time without actually bringing anything into the mouth. And I also think it's a novelty from the historical perspective of CAD/CAM dentistry, where maybe 5-6 years ago, if I wanted models mounted on a virtual articulator, I needed to physically mount them in the articulator and scan the entire articulator mount itself. And here we did everything in reverse. We took strictly digital information and we brought these elements onto a virtual articulator. And now I would like to take that mount and bring it onto my physical articulator, which I do by means of the plane positioner that I showed you in the second course, where we will load, this green plastic plate called jaw positioner. We increase the table height so that it intersects with the maxillary position, and we will go to then mill the intersecting area or the impression that the maxilla left in the jaw positioner, and this will then receive our milled, printed, or poured model, and we have now the mount transferred to a physical articulator. And so now we've established the technical project both in the digital lab space as well as the conventional lab space, and we go to begin our prototyping. And if we want, we can start with a simple non-invasive appliance. So let's say a patient presents like so. The patient's overclosed, they're missing some teeth, there's gaps in the teeth, they have some serious abrasions going on. We can already imagine that there might be some dysfunction with the TMJ, and we will simply capture the appropriate bite registration and then take all of the scan records as previously demonstrated. We bring our patient into the virtual waxing station and we go to do a full mouth tooth setup, upper and lower, which we can test on a virtual articulator. And in the first iteration, this will be milled as an anatomic bite splint in a material called multistratum flexible. It is a polycarbonate material with a seamless shade gradation running from the cervical to the incisal edge, and this will snap over the patient's dentition. And we can use this not only to make the patient comfortable with the treatment that we are ultimately looking to provide, but we can use this more importantly for a functional assessment and an aesthetic assessment prior to an invasive therapy. And I believe that this is an amazing service that laboratories can provide their clinicians when going after full mouth rehabilitations, to be present in the clinic, to capture these records, and to come back and deliver a simple mock-up that the patient can go home and wear. We are selling the patient into the case while getting very important clinical feedback prior to an invasive therapy. And I think that the doctors will really see the intrinsic value in this type of service that we offer them. And it really strengthens our interdisciplinary collaboration as we go to do more cases together. And so certainly the patient can wear this appliance for a number of weeks, and they will integrate their own individual occlusal abrasions, which we can now bring back into the project as a new pre-op scan, a new C2 scan, and we could even go to imprint those individual occlusal abrasions on our invasive prototype. So we're one step ahead of the functional therapy. So we bring all of these elements back into the project. I will say this is a different patient, but just follow the logic here. And we can then merge the CT scans to that mount, and we can use some of those principles I showed you in the first cases, where we can go and cut scans and perform a virtual tooth extraction to our needs and necessities without losing sight of the references that we need from the pre-op scan. So these are all interposed with one another, and they're properly mounted on our virtual articulator with the 3D face scans, and also with the introduction of tried and true reference objects such as the Monson sphere, which, as we know, is more or less 8 inches in diameter. It intersects with the eminence, and it helps us to understand the curve of Spee and the curve of Wilson of the mandible. And we simply have all of these elements together on the screen. We can see the pre-op scan in relation to the working model and the Monson sphere, and we can ask ourselves, well, if I want to preserve the pitch of that central mandibular incisor, perhaps I need to increase the vertical dimension. And so we can use all of these tools to really make amazing functional assessments before we go into the mouth with our prototype. And what we're getting at is essentially a formula where we will draw the blueprint, the engineering plans of our prosthetic before we go to place pillars in the mouth. I'm talking about pre-operatively fabricating the tooth setup in a patient-specific manner so that we can eliminate transmission errors and we can promote function and aesthetics and stability over the implants. We go to save this structure out, and we do the same for the upper jaw, this time with another set of references, the 3D face scans, and perhaps a golden proportion table split left and right for the deviations in the patient's individual occlusal plane. And we simply go to place the teeth functionally and aesthetically. We can start to understand what the triangle between the lateral and canine does to allow light into the smile. What does the little point on the incisal edge of the lateral do to really add these tiny aesthetic quirks that really make a prosthetic lifelike? What if we open the central incisors and give them a butterfly effect? We can see all of these things in real time and with a variety of different tooth morphologies in the various Vita shades. And really, we come to one of my favorite parts of this presentation, where look at all of this information we have on the screen at our fingertips, at our disposal. We have the 3D face scans in relation to an STL rendering of the skeleton data in relation to our proposed virtual tooth setup. So this is like the blueprint for a house that we're about to build. And now it's time for us to understand how that structure is going to be supported in the mouth by means of implants. And really, we can use virtual tools to improve the interdisciplinary collaboration between the restorative team and the surgical team. I believe at a minimum, it's fundamental to assess the virtual tooth setup on the DICOM. And yes, maybe the clinician doesn't want to work with the surgical guide, but at least having this conversation really will take us one step ahead of the pickup technique. For an example, you see in the lower right-hand corner, we've eliminated the second premolar because the surgical team was dictating that an implant be placed in what is now the center fossa of that first molar. And so just by having the conversation and using digital tools, we know that we can just eliminate that second premolar. We can widen the molar a little bit, reposition it, and we can eliminate the cantilever that would have inevitably occurred were we to keep all those teeth in the mouth, and we can promote stability of the structure over the implant because now the implant's not jutting out of interproximal space. But we can also take it another step further and go through actually an implant planning phase in the Zirkonzahn software suite where we can plan the surgery from a prosthetic point of view and generate a surgical guide which we can mill alongside our immediate provisional. And we bring this into the mouth, and we are much further along with our pickup. We might just have to widen one of the screw channels so that we can get the passive fit that we're looking for in a chairside conversion service that a laboratory should be offering their clinicians when we're going after these cases. And if the doctor doesn't want to work with a surgical guide, we also have new types of digital denture conversion techniques that are more of a post-processing approach, but still we can use tools like this to really cut down on the time. If we go through the same setup procedure, the same technical project and prototyping concepts, we can then mill half of the restoration prior to surgery, and then we can pick up the post-op model and cross-mount it to our pre-op, integrate photogrammic records if needed, create a digitally verified implant model, and receive the basal aspect, the implant positions, and the implant platforms and screw channels, and mill this after the surgery. So if we're nearby a clinician, we can drive this over right after the surgery so we don't have to sit chairside, and essentially the patient is waiting the same amount of time to receive the structure as they would be in a conventional method. But we as technicians have freed up our time to go do other equally important tasks. It looks like I'm getting a little short on time, so I will just quickly go through the aesthetic try-in concepts. If we go to bring the structure after it's healed back into the software, we can really start to get an assessment of the mistakes that might have been made in the immediate provisionalization, where we're not perfect beings and we have to roll with the punches. This is the intersection of a rational approach with an empirical approach, and there will be some very, very slight deviations in the plan, and that's to be expected. But we can use the technology to get us near close to 100%, and then bring everything back into the software, assess the mistakes, and go to correct that through a final aesthetic try-in process where we will go to create a reduced framework, and we will adapt all of those pre-operative setups that we previously demonstrated, and we can mill all of these elements in resin and bring them into the mouth on the day of the aesthetic try-in, and get a sense for what does that triangle between the lateral and canine do to bring light into the smile, or what does that point on the lateral incisal edge do to give the tiniest little aesthetic quirks. What if we shift the laterals back, or what if we go to open up the central incisors to give them a butterfly effect? And you can see that really the technology is bringing us very, very close to what we are looking for, or what we're getting out on the other side when we go to mill these structures. So we can start to place a lot of faith in these tools to provide us accurate and predictable results. And at the end, the patient goes home with this ledger of different setup options, and they show their family, and more importantly, their friends, the types of services that the doctor is providing. But we need to remember that this is being driven by means of a CAD/CAM laboratory procedure. And so as laboratory technicians, we can use these as marketable services to go after these types of cases. And we can see the amazing transition that the patient has undergone. And really, that's the scope of how we would approach the full arch prototyping. And you can see that these projects are very, very elaborate and require a lot of know-how of working with the software. And that's why we start off with these very simple cases to build the basin of knowledge required to accomplish these types of cases within the software. And I really do think that at Zirkonzahn, we have a beautiful program laid out for any newcomers to follow our model of we forge heroes to make you the best in your city. We're simply a humble company that started out of South Tyrol, Italy, with a manual milling machine, and we grew into a complete CAD/CAM solution, from the desktop scanners to the software itself, the milling units of all shapes and sizes, and the final materials required to put the restoration together. And we will teach you how to do all of these things in our world-renowned training centers. And it's not only a matter of teaching you how to move the patient into a scan software, into the virtual waxing station, through an implant planning studio, and through a CAM solution, but it's a matter of also supporting you on a daily basis and being there to give you pointers, give you tips and tricks, get over any little hiccups that come along the road. And I think that that's a very important consideration if you're going to partner with the CAD/CAM company. That yes, it's not just a simple sequence, but there's a lot of legwork required, and we need to understand who are we partnering with, how are they going to guide me to the end result of my business objectives, and how are they going to support me on a daily basis. And this is really the scope of what I wanted to share with you guys today, is that we have this really amazing educational program and support team that will take you from the very beginning to these beautiful types of full mouth reconstructions. And certainly we're not limited to that. We also have a lot of know-how with removables and telescopic works, functional appliances, the list goes on. So I really appreciate everybody taking the time to attend today's session. I'm going to stop sharing the screen.